Next is my honor to introduce our one of our honor speakers for this course this year, Dr. Richard Fessler, who is internationally renowned. I don't think really need too much introduction, but just to highlight a few things he has done. He's a pioneer in the minimally invasive spine arena, where a lot of us, nowadays we do MS TLIF and the posterior cervical front through the tube. That's all through Dr. Fessler's work to a large extent. And then also in the spinal cord injury research, Dr. Fessler has contributed a tremendous amount of literature and data for this current state. And on a more personal level, I was fortunate enough to train with Dr. Fessler when he after him being the chair at the University of Chicago and spent some time at Northwestern and University of Florida, come to Rush. I had the privilege to train with him, and just one quick story. My PGY 4-year, I think we're doing a microdisc. I remember vividly. I think he has to go check on another room how they were doing or set up. He said before he left, he was like, "Lee, don't get a CSF leak. This guy, I go to him for my blood pressure medication. It says like PCP." 5 minutes later, by the time he comes back, guess what? We're swimming under the tube. So now, I'm 8th year in my practice, and when we have, fellows and residents, have a durotomy, I can't really say anything to them because, what you did, because you were so calm and kind, and you said, okay, let's fix this together. So. But without further ado, Dr. Fessler, thank you.
Well, Lee, that's not the first time, it's not the last time that's happened. So thank you, Lee, and thank you, Kyle and Lionel, for inviting me. I'm delighted to be here with y'all. And Bobby, I'm really glad they put you in between Sig and me, because Sig is a really hard act to follow.
It's clearly hard to follow Sig. He's dresses better.
Well, I don't know. You look pretty good. So these are my disclosures, and the yellow one is the important one for today. The 3 studies I'm going to talk to you about, I was the principal investigator on, and I'll try and present the results as unbiasedly as I can. So we're going to talk about spinal cord injury. I've been working in spinal cord injury for 30 years. It's become a very big part of my basic science research and my clinical practice and research. And it's interesting. We get about 18,000 new cases every year in the United States. There's about 350,000 people living with spinal cord injuries. 2 weeks ago, I was at a meeting in San Diego, which is a fundraising event for one of our next spinal cord injury trials. And we had a bunch of individuals there who are living with spinal cord injuries. And we had them on a panel telling us what their life is like. I learned, even though I've been taking care of patients for 40 years with spinal cord injuries, I learned so much from sitting down and listening to them. Things that, things you don't think about, like, okay, I'm going to have a couple patients coming into clinic today with spinal cord injury, and my clinic starts at 7:30. They have to get up at 3:30 in order to do all their personal things they have to get done before they can even come to clinic. So they changed my practice in that simple statement. So what is their life like? Well, the majority of patients with even thoracic level spinal cord injuries are unemployed, and their lifetime healthcare costs are exorbitant. They have limitations in their mobility. We're getting better in the United States for allowing them to get around, but we're not great yet. They have high incidence of neuropathic pain, multiple rehospitalizations, multiple infections. Some are ventilator dependent. Almost all of them suffer from depression, and they still have a shortened life expectancy. And we want to talk about cost. I mean, think about this. So if you're a low-level thoracic injury and you've got some motor function and you are 25 years old, your lifetime cost of care is going to be $1.5 million. But if you're a high quad and you're 25 years old, your lifetime cost is going to be more than $5 million. And multiply that times 350,000 people, and you get an idea of what a tremendous burden this is on our thing. So if we can take a high quad and change them into a low quad, we can change them from $5 million to $1.5 million cost to our society for their lifetime. So what led to the stem cell trials we're going to talk about? Well, I was fortunate enough, my first job was at the University of Florida. And when I went there, they happened to have one of the best spinal cord injury regenerative medicine groups in the country. And I was able to become the clinical component of that. They were able to demonstrate that they could take rat fetal tissue, and cat fetal tissue and transplant it into either a spinal cord injured rat or cat, and it would grow, and it would fill the syringomyelic cavity in those animals. And not only that, but they would get return of locomotor function, and they would get improved hind limb function. At that point, when we brought this data to the NIH, they came to us and said, let's create a consensus conference. We're going to bring together, I'm not sure if I have that slide. No, I don't. We're going to bring together all of the major clinical, rehab, scientific people on spinal cord injury in the United States. We're going to have them go through your data, and we'll decide what you have to do in order to take this to the next step, which is a human trial. And we did that, and they came up, and they were looking through all the Parkinson's transplant studies data, the complications and all of that, and they came up with one or two things they wanted us to do, which we did, and brought the data back to them, and then they said, okay, you can go ahead and do a human trial. So we didn't have stem cells then. So how are you going to do a regenerative medicine study if you don't have stem cells? Well, the best thing we could come up with was human embryonic spinal cord tissue from voluntary abortions. So I'm in the Bible Belt, and number one, we're going to be going to do abortions, and we're going to be taking human cells and transplanting them into humans. So I got a serious death threat, and I had a police escort around my house, and my children had police escorts for 3 months after we did this. The day we did this, the entire operating room was locked down. There was one operation going on. That was our transplant. Nobody else was allowed in the operating room. So what we did was we went to a local abortion clinic and got consent from women who are going to have voluntary abortions to use the spinal cord for this study. And we would collect the spinal cords, make sure it was sterile, there were no contaminants or anything, and then we would dice it up or create little slits of it. And so we're only talking about an 8-millimeter piece of spinal cord here. And then we would transplant into patients who had syringomyelia chronically, and were going to have surgery for their syringomyelia anyway. So this wasn't an operation they weren't going to have. We were just adding one step, and that is transplanting this tissue after we drained their syrinx. And this was our group. The people in yellow are the primary people, but we had a very large group participating in this. The major aim of this study was just to test feasibility and safety. Was it feasible to try and do a transplantation using this kind of tissue, given the way we had to collect it, and was it safe to do? And then we were going to look at outcome. So we were approved to do a non-randomized study with 8 patients who had syringomyelia. They were going to get the transplantation. They were going to be temporarily immunosuppressed with cyclosporin. And then we did all of these functional measures to see if, in fact, we're going to get anything. And we could only do thoracic level injuries because we felt that was the safest. It's least likely we're going to harm anybody at the thoracic level. So our surgical procedure was first to detether all the adhesions from their original injury and then decompress the syrinx either with a needle aspiration or a myelotomy, and then graft. Our grafts were all in the thoracic spine. We did one up to the C7 level eventually. And then we were using minced pieces or strips. And we had to have 8 donors for each individual patient because there's so little tissue that we combined 8 donors for every single one of our transplant. And ultimately, we were hoping to be able to do this minimally invasively. So this is, for example, an ultrasound of this multiloculated syrinx before drainage and transplantation. And here you can actually see our transplanted cells right here. So we did 6 males and 2 females. All of them were between T4 and T12, except the last subject was C7. The time from injury to enrollment, these were all chronic, 12 to 31 years. And they were presenting as typical syringomyelia patients tip, pain, weakness, spasms. They had an average of 0 to 5 shunts prior to our transplantation, and the size varied from 1 centimeter to the entire spinal cord. This study has been published previously. So there were no intraoperative or postoperative complications. There was no neurologic deterioration postoperatively. Immunosuppression had no negative effects. We felt that the tissue could be reliably and safely acquired, and the transplantation procedure was technically feasible, but the amount of tissue was never enough to actually fill an entire syrinx, except for the tiniest one that we had. So although it was technically possible, it really wasn't feasible to proceed in this particular way. The results were that the small syringomyelineutic cavities were filled completely, the large ones were not. The areas that were collapsed and transplanted never reaccumulated, but the areas around them did reaccumulate slightly in following them out. We could actually image our tissues on MRI, which was really important. That was one of the important things we had to do. We had substantial obliteration of the graft site in 7 of 8 cases. And we can show you a couple of examples. So this was actually our very first patient, and you can see that his syrinx extends from the base of the skull all the way down to the cauda equina. His injury was originally at T5, and pre-op and post-op you can follow very large syringomyelineutic cavity here, essentially gone 2 years later at the point where we did the transplantation. This is another patient. This was the smallest syrinx we did. Little one here. This was 31 years out from injury, and we were able to completely obliterate that. And you can see that in axial section as well. So there were no major neurologic events. 2 patients had mild sensory improvement in the thoracic spine. 1 patient had a dramatic motor improvement. And so this is the ASIA scores, and you can see they really aren't changing. Total motor scores didn't change. The individual looks, they really didn't change. This is the one patient that we had an amazing result in. So this is her gait preoperatively, and you can see that she's using a cane in each hand, and she's able to step with this. She really drags this foot along. This is her gait postoperatively, and I want to show you her video. So we did 2 things. We had her walk a self-selected pace, so a gait that she feels comfortable with, okay? And this is her doing that. A couple things to notice. So she's using 2 canes. She's dragging her right foot. She cannot elevate. She can't dorsiflect her right foot. And she's watching her feet all the time. Oh, shoot. And then we had her walk as fast as she could. And so this is her walking as fast as she could. And I want to show you her a year out. So she's lifting her foot, she's not watching her feet, and she has no canes with her. So this is when we knew we were onto something. There's something here that we can work with. And then she comes back and she says, I'm going to go on Oprah, by the way, and talk all about this. So he said, please, please don't do that. So there's actually been a lot of transplantation studies done in the worldwide literature if you look at it. So, and they've been in a lot of different ways. So there's mesenchymal stem cell injections directly into the spinal cord. And there have been a number of these done around the world with a reasonable number of patients. And some of them saying it's safe, some of them saying they got slight improvement. They really didn't define what their improvement was very well. It's very hard to know exactly what was going on. And then we have intrathecal injection of mesenchymal stem cells. You guys might have remembered a year ago the Mayo study came out and showed this patient who got a miraculous recovery doing a single intrathecal injection of mesenchymal stem cells. Nobody else has seen that, and I haven't seen any follow-up yet, so we'll have to see. But everybody's saying that there's a slight improvement. And Sig was kind of alluding to this. You know, we've made a little bit of progress in the regenerative medicine field, but we still have a long way to go. And then there's IV mesenchymal stem cells. Most of these have been done outside of the United States. There's neural stem cells into the cord, again showing some slight improvement. There's Schwann cells into the cord. This is the Miami group. They're the most conservative. They're not going to say, we've got improvement, but they are saying we can do it safely. And then we've got olfactory stem cells into the cord, and unfortunately, olfactory stem cells have created a lot of tumors, and that's no longer being done. We couldn't, it was kind of a neat idea because, you know, this is a cell that goes from the central nervous system to the peripheral nervous system. That's sort of what we want, but we can't clean it up enough to stop it from creating these mucus tumors. And then these are the two studies I'm going to tell you about now that we've done in the United States. So the idea of these studies, this is an oligodendrocyte precursor cell. So it is a stem cell that's going to make myelin. And the theory is that following a spinal cord injury, some of your nerves are completely dead, they're transected, but some aren't. They're potentially functional, but they're demyelinated. So they don't function in the way nerves have to function with the myelin coating. So if we can remyelinate them, maybe we can return some function. Originally, this was a stem cell that was created out of a single aborted embryo from about 1995 at Madison, and it is now a continuously regenerating line. So these cells could have three kinds of effects. Number one, it can remyelinate nerve cells, as we can see right here under electron microscopy. It can create neurotrophic factors, and it causes revascularization. So three good things that we want to happen for a stem cell transplantation to take and have a good effect are there. And we knew that in animal models that we can create a defect and that we can fill that defect with these cells. And in rats, we found that they had improved motor function. They had better weight bearing. They had better hind limb forelimb coordination. They had improved hind limb clearance. And that's what we're talking about, dorsiflecting that foot so you can actually take a step. They had better stability in trunk, and they had decreased lag. And we also found out that these cells will decrease the amount of neural death within about 2 centimeters of where we transplant. After that, it loses the effect. But within 2 centimeters, we can actually keep these neurons alive. So this was published. The next thing we had to do was, prior to doing our next study with these stem cells, the NIH again wanted us to prove we could do it safely, so we actually did the operation in pigs to prove that we didn't create any kind of a neurologic injury or a tumor or a syrinx. And so after we did that, they allowed us to do our first study. So we were approved to do thoracic level again, 8 to 10 subjects, just not randomized, between T3 and T11. We were allowed to inject 2 million cells, and it had to be done within 14 days of injury. That turned out to be really hard because most of these patients are being injured outside of our hospital. They're being operated outside of our hospital. They then have to be transferred to our hospital, and you have to undergo 7 days of testing to prove that they're a candidate for this. So that was really tough, but that's what we had to do. Our primary assessment was safety. Our secondary assessments was a whole raft of neurologic, and you can see that we are following these out to 15 years. This group of patients now has 10-year follow-up. And this is, we're allowed T3 to T11. We created a stereotactic positioning device so that we could inject it precisely where we wanted to in the spinal cord. And we only did 5 patients because Geron decided they wanted to put all their money into cardiac regenerative medicine rather than neurologic. So they cut the study after 5 patients. So we had a few screen failures in looking at our first 11 patients, And the screen failures were because we have to be able to image the spinal cord after surgery. And if they had too much instrumentation in place, obviously that interferes with your ability. So we had a bunch of screen failures because of instrumentation. After that, however, we didn't have anybody drop out. And we've now followed this group out for 10 years. So they were at our site for 2 to 5 days before surgery, complete physical exam, vital signs, neuro, the INSCI exam, pain assessment, SCIM questionnaire, GRASP evaluation, an MRI and brain MRI without contrast right before surgery, and in all the specific labs for blood chemistry, hematology, and immune response monitoring. So, first thing we did was look at all of our adverse events. So we had a total of, I think, 400-something adverse events, 25 possibly related. 9 of them were related to the injection procedure, pain at the injection site, fever, urinary tract infection, and 16 possibly related to immunosuppression, which was nausea, low magnesium, and infections. There were 5 major adverse events. All of them were unrelated, and the kind of things we expect with a spinal cord injury: pyelonephritis, urinary tract infections, autonomic dysreflexia, psychiatric mood disorders, depression, in other words. So none of them were related to either the immunosuppression or the stem cell transplantations themselves. And not surprisingly, in thoracic spine, we really didn't get any kind of an effect. 2 patients felt they had a little bit better sensations. 2 patients felt they had a little bit less sensation. 1 wasn't sure. And we, about a year ago or 2 years ago, we published this result in Journal of Neurosurgery Spine. So the real test comes in, though, is in the cervical spine. Because in our animal studies, we demonstrated that we could keep cells alive for up to 2 centimeters and remyelinate over that period. Well, in thoracic spine, that doesn't make any difference, right? Cervical spine, 2 centimeters is 2 functional levels. So if we can do that and keep 2 functional levels, maybe we can actually get an effect. So they next allowed us to do a cervical study. We were going to do a dose-response study. So cohort 1, 3 participants with 2 million cells. This essentially is our control group. 5 patients with 10 million cells and 6 patients with 20 million cells. Our results were good enough that the FDA came back to us and says, go ahead and do, these are all Asia A's, came back to us and said, go ahead and do some Asia B's. Let's see what you can get with that. So this time we pushed it out to 21 to 42 days post-spinal cord injury. We don't know how long we can go and still get an effect. In rats, it's about 6 months. But there have been a few studies done in humans in chronic patients where they've reported some improvement. So we really don't know yet how far out we can go, but we wanted to push it, so we pushed it out to 40 days. And it was the same kind of study with repeat MRIs. For the first 2 years, they come into the hospital for complete examinations on all of those things I just told you about. After that, we do telephone follow-ups for 15 years. And so now we were approved to do initially C5 through C7. And then again, the results were good enough. They said, go ahead and try C4. So why is this important? Well, we know that obviously in cervical spine, it's very much dermatologically striated, so if we can get 2 levels, look at the difference. So here is a C4. C4 is 100% dependent upon somebody else to do everything for them 24/7. C5 can do a few things by themselves with partial assist. C6 can do a lot of things by themselves and require partial assist for bowel and bladder, and maybe getting from a wheelchair or getting out of a car, stuff like that. C7, 8, they're almost totally independent. So we can have a major quality of life change if we can change a C5 to a C7. And that's been demonstrated in previous studies in how much they get, how much independence they have depending upon the level they get back. So we did not have a control group for this. So what we used, there's a European spinal cord injury organization that follows all of the spinal cord injuries in Europe very closely for years and years and years. We use them as our control. So this is how the surgical procedure is set up. We've got our stereotactic device. We open their previous incision. Some of them have had laminectomy, some have not. If not, we do a laminectomy, and then we We very slowly lower the Hamilton syringe into their spinal cord, and in over 2 minutes inject 50 microliters. So I learned a little lesson here. So those of you who have worked in the lab know how sharp a Hamilton syringe is. So the PIA is so strong, I could not pierce it with a 25 gauge Hamilton syringe. I had to cut the PIA, and it's only 2 cells thick. I had to cut the PIA with the scalpel in order to get the needle through. So, just a brief video on the surgical technique.
These are embryonic stem cells being injected directly into the site of injury in the neck. Special cells produce myelin, the protective sheath that helps nerves function normally. Function is lost.
This study is being done in the neck, when the cells only have to grow on the center.
Okay, so that's just a quick thing. So yeah, it's the IMSCI database that we used as our control. We matched all of our patients to an exactly matching patient in their database and then compared their results. So this is a 1-year follow-up on this group. So we had 100% follow-up on every single patient in every single cohort. And what we found was that when we looked at their motor recovery, this is the IMSCI database, and these are our patients. So we were getting more than twice as much of an effect as the patient who has not had a standard transplantation. And when we looked at individual muscles returning, this is the IMSCI database. They would get about 8 individual muscles. We had about 12 and a half return of function in previously paralyzed muscle groups in the upper extremity. In the end, what we demonstrated, I think this slide is out of position, but I'll do it anyway. In the end, what we demonstrated that every patient except one, 96% of our patients got one functional level back. And I'll show you the one patient that did not. It turned out to be my patient, actually. 32% of our patients got 2 functional levels back, so they went from being C5 to C7. Again, looking at our adverse events, 500 total adverse events, 29 serious adverse events. The only 2 that were potentially related one was related to the injection procedure itself, and that was a CSF leak, and the other was nausea related to, or an infection related to immunosuppression. So for the 5 patients that didn't do so well, it turned out 3 of them were C4s. So maybe that's our upper limit of where we're going to get a functional effect, a C4. We don't know that for sure yet. The other 2 patients that did not get a good result turned out to have epidural hematomas. One was an incomplete decompression, the other was an epidural hematoma. So those are the 5 patients that really did not do as well as the other. This is my patient that did not do well, and this was our pre-op, and what it turned out that it was a functional transection, so he had nothing left. And on the other hand, this kid lives alone, drives a car, and is fully employed. Here's here's the epidural hematoma that we had, and the other was an incomplete decompression. So, overall, our results were really excellent with minimal evidence of device or immunosuppression-related complications. We had a very high rate of recovery of at least 1 motor level and quite a good recovery at 2. Our 2 issues were the C4 level patients who did not do well and the post-op cord compressions that did not do well. And I'll give you just one example of one of our patients. This patient was in a horrible, horrible motor accident. He was a complete C5 quad. And this is the Milwaukee Brewers baseball game. And he is throwing out the first pitch. And he threw it further than most of the celebrities. So in conclusion, these stem cells can be administered to patients subacutely safely. They have no serious adverse events. There have been no tumors, no neurologic deficits. The dose response, we got our best result at 10 million cells, not 20 million cells. We're not sure why that is yet, but that was certainly the case in our first study. And it's certainly clear that thoroughness of cord injury and decompression is important in our ultimate results. So I'm rather bullish on the future. We haven't done as well as I would like to have done. One of my goals when I started this research was I was going to cure paralysis. I have failed, but I think we're going to continue making progress for these patients. Thank you.
Great. Professor, that was a fantastic talk. And I remember actually doing, I think, the second case in the country with you in residency. One question is that, in the literature recently, there has been shown some efficacy about spinal cord stimulation post-injury to help recovery. I'm wondering if, has anybody looked into, both for stem cell transplant on top of the spinal cord stimulation, or if you're increasing the signal going through the injured level when you have a cell with sort of a potential to differentiate, maybe that would be sort of enhancing its benefit.
Yeah, that was some really exciting research. I agree with it. And I would love to be combining these technologies. And there's a few other things being done experimentally for spinal cord injury too that would dovetail very nicely into this, because this isn't going to be the only part of the answer. I think we'll be doing a combination of neurotrophic cells, stem cell transplantation, electrical stimulation, but you can imagine the problems getting this through the FDA. And then what you're talking about too are two different technologies and two different funding groups for those technologies, so trying to get them to work together is another crisis. But it's going to be some combination of these things in the end. It's not going to be one. Yeah. Or you got it. Go ahead.
This is a little bit off topic, but any thoughts on using stem cells for root level injuries?
That's what the Miami group has studied a lot, because they're using swan cells. And so that's the transplantation that you have to do there. I'm sure it's been done, but I'm not familiar with that literature.
Thank you. I was wondering, are you doing anything outside the studies currently on regular spinal cord injury patients at the level of stem cells or whatnot at your institution?
We're not allowed to. Right now we're actually running just 3 institute study because we've developed a new device to put it in. It's much smaller and less coned down. And as soon as that study's done, then we will open up our next study, which will be a cervical, probably just cervical, but it's going to be most likely a combination of acute and chronic. And the FDA wants us to do a randomized controlled study. And I understand the importance of that, but I don't know how we're going to do that. If I'm doing a drug study, I can say, yes, you might be in the placebo group, but in 6 months we'll flip you over and you'll get the drug and it'll be fine. As far as we know, 6 months stem cell transplantation doesn't work. So I can't do that. So there are 3 major criteria you have to do to ethically do human research. One is that you have to have true equipoise, meaning you don't know if it's going to work or not. Well, we know it works, so we don't have equipoise anymore. Number 2, you cannot ask the patient to give up their potential benefit for the future benefit of somebody else. So the patient who's going to be the non-transplant group knows they're not going to get any benefit, but maybe someone, because of their sacrifice, will get it down the road. You can't ask them to do that. And number 3, you can't put the control group at increased risk. Surgery is a risk. So I don't satisfy any of the 3 major criteria internationally recognized to do human randomized controlled study here. So I don't know how we're going to do it.
Hi, my name is Omar. So just a couple of questions. You mentioned you used a 25 gauge needle to inject the cells. Is that the needle that you normally use? And have you seen anything in vitro of the share of the
Yes.
gauge of the needle on the effect of the cells? And
Yeah,
then,
we looked at that, and there was no significant effect.
Okay, and if your volume was the same for 10 million cells and 20 million cells that you injected?
No. For 10 million, for 2 million and 10 million, the volume was the same. For 20 million, we did 2 injections of 50 microliters, one below the injury and one above the injury.
Okay, thank you.
Great. Thank you, everyone.